when selecting a patient with sideroblastic anemia for allogeneic transplant, several factors must be carefully considered to optimize outcomes and minimize risks. So these key factors in patient selection for transplantation are the disease severity. So patients with sideroblastic anemia or very sideroblastic anemia are the primary indications for allo. Also, patient age is very important. So younger patients, this is defined as ages below 40 or 50 years old with an available matched sibling donor are the first-line candidates for allo. Other patients or those without a matched sibling donor may receive immunosuppressive therapy first. And for patients with ages above 50, allo is considered case by case, balancing frailty, comorbidities, and also a donor option. So also it's important to consider the donor availability and the HLA matching. So the preferred donor hierarchy is that HLA matched sibling donors are the ones who provide the best survival and lowest transplant-related complications. The match-related donors should be considered if a matched sibling donor is unavailable. With respect to the mismatch unrelated donors or haploidentical donors, this is an alternative when a match unrelated donor is not available, often requiring post-transplant cyclophosphamide for GVHD control. And umbilical cord blood is less commonly used, but remains an option, especially in pediatric patients. With respect to the timing of transplantation, early transplantation improves survival and reduces complications. And delayed transplant, especially after failing immunosuppressive therapy, may increase the risks due to the transfusion burden and also infections. It's important to consider the comorbidities pre-transplant and also the performance status. So patients should be with a Karnofsky performance status above 70%, more or less. Also the comorbidity index, because higher scores predict worse outcomes. It's important to consider if exist pre-existing infections such as active fungal or viral infections that can increase the post-transplant mortality risks. We have to consider also the previous treatment and the history of transfusion. So patients failing immunosuppressive therapy are transplant candidates. Those with transfusion burden with multiple red cells or platelet transfusions increase alloimmunization risk and may lead to graft failure. And also the clonal evolution, so patients developing MDS or AML may require urgent transplantation. Also, we have to consider the conditioning regimen tolerance. So standard regimens include fludarabine and cyclophosphamide with ADG, often also with TBI, especially in haplo and mismatch unrelated transplants. Normally, we use reduced intensity conditioning, and this may be used also in older or frail patients to reduce the toxicity. So, in conclusion, I would say that the decision to proceed with transplantation in aplastic anemia is balanced between the disease severity, the donor availability, the patient's fitness, and the timing. So, matched sibling donors transplant remain the gold standard, while match-unrelated donors, mismatch, and haploidentical donors are options, expand options access for those without a matched sibling. And I think it's important that early referral to a transplant center and careful patient selection are crucial to achieving the best outcomes.